share some insights, some answers on the different questions that maybe you have. And today, my question to you is, are you interested to making a lot of profits from the German market? And this is just an open question to you. I don't think the answer right now, but today we got I think a great guest that probably can help you to decrypt in a way the German system and to provide you with some advices on how to sell your medical devices on the German market. And so welcome, Marco Wender. Hello. Marco, thank you very much for joining today. You are the CEO of Medical Valley European Metropolitan Region Nuremberg Association. Quite a long name, so for the purpose of this event, I will just say Medical Valley. Thank you very much for accepting this short name. Thank you very much, Marco, for your time, and thank you for your presence today. I'm really happy to have you today, since Medical Valley is undoubtedly one of the leading innovation ecosystem in Europe, and especially in the healthcare management in different forms. Most importantly, Medical Valley has been supported companies since a long time, probably more than 20 years. You got dedicated program to support the companies. Just to provide you with some numbers, in the last years, you have worked with more than 200 companies. Startup companies, really impressive. And in the last years, I admit that you are emerging like a champion in Europe in supporting companies in how to reach the German market, the device in the medical device area. And that's the reason for why we are very interested to have you today, to listen to your presentation, to understand the tricks, and to ask you, of course, all questions regarding how to reach that German market. That is one of the biggest in Europe, of course. Well, Marco, I hope that your slides are ready. If you have no questions, I think that I can leave you the floor for 30 minutes, and then we will open the floor to the questions. Marco, thank you very much. You can start now.
Yes, thank you very much, Jean-Philippe, for this kind introduction, and thanks to everybody for joining this webinar today. I just have 30 minutes to explain on the German market access and explain a little bit strategies. So I keep it rather short, and let's discuss later on. So my presentation will just focus on a few aspects of market access, of course. Some basic thoughts on market access. Bringing your product idea to the German market, I mean, it's pretty clear at a certain point you have to get CE approvals. That's more or less possibility of selling your product in all European markets. And then it's all about the business model, the reimbursement by payers versus self-payers. And that's what I want to stress on today, really the German market perspective, especially focused on reimbursement as one important step towards market access or successful market access in Germany. What do we want, or what do I want to cover today? It's about the German healthcare market, the German healthcare system, a little bit background information for those of you that don't have a clue on what a German healthcare system looks like. Introducing you the payment methods in the German healthcare market, as it is an important factor. Who is paying for what kind of service and who is paying then the companies? The challenges of market access in German healthcare market, and finally coming to the pathways of reimbursement. So let's first go to the German healthcare market. The German healthcare market is, of course, due to its pure size, very interesting for many companies making business there. We're having around 85 million people in Germany, some healthy, some patients. So it's an important market for prevention topics, for healthcare topics, and we are spending a lot of money really in the healthcare market, so around 474 billion euros per year. That's 13.2% of our GDP, what we are more or less spending in healthcare. It's more or less a system that is driven by health insurances. You can see it here on this slide. Around 60% of the, or 62% of the spendings in the healthcare sector are done by health insurances. Just a few or 13% in total spent by private households. So it's not so the pure self-payer market in Germany. That's a factor, but not a big one. It's more or less really in this health insurance market. Coming to the major components of healthcare spending, just a short outlook. Around 30% are for healthcare goods, around 30% for medical services, and other 30% for nursing and therapeutic services, and a few other spendings. From this 474 billion euros, there is much spent in all types of fields in the healthcare sector. So for most companies, something that interests your services or your products. In Germany, we have a broad hospital infrastructure, around 1,890 hospitals across the country, divided into private, public, and non-profit. The number is declining indeed, so there are much concentration processes, but still a large number of potential customers in the hospital field. But also in the outpatient sector, we have a really high number of potential customers, so around 409,000 practicing physicians, the number increasing. There is a big shift from inpatient care to outpatient sector care. And the number of physicians really increasing very great. But to be honest, we have some problems also in the German healthcare sector, of course. So the funding is okay, but it is not enough. So currently there are some major changes in the system, and Germany has to really check where the money has to go in, and what types of services are really paid by the health insurances, or what is since more or less coming to the self-payer sector. Let's go a little bit deeper in the healthcare system. You must not read it. That's just my basic intro slide. It shows very much colors, and this is just more or less a kind of overview about how the different players and aspects of the German healthcare system interact together. And it's always just shows the complexity of the German healthcare sector. But this is not of big relevance for the healthcare providers, because with most of the people in the German healthcare sector, they have no real connection to. It's more or less about three fields within the German healthcare system. This is on the one hand, the public health agencies. So these agencies that are dealing with public health topics, especially you normally don't see them. Corona showed a little bit in Germany about the public health agencies, because they try to gather data as support for making decisions. That's just a really minor part of the German healthcare sector, mostly public, and in each of the German Länder, one public health agency that is supporting the Länder to make their decisions. What is the biggest part in German healthcare system is the central part. It's really the healthcare, the inpatient and outpatient healthcare with health insurances that are more or less the payers of the healthcare. And also long-term care, the elderly care institutions, where is an own insurance paid by the working force of Germany, where this long-term care services are paid. So this is normally a kind of more streamlined and more easy and reducing complex overview about the German healthcare system. What to be said in the healthcare system part is just Germany is driven by health insurance payment. So it's not more or less paid by taxes, like for example in Denmark. It's really health insurance, and every German person is health insured, and the health insurance is normally paying the health care services. Then let's come to the payment methods. I already mentioned that normally it's about healthcare insurance payment. So really who pays for the service? Normally for German healthcare, it's really the insurance that pays, but there are also out-of-the-pocket payments. And this is why you can define the healthcare market in Germany into two parts. The first one is the primary healthcare market, where the inpatient and outpatient healthcare more or less is located, and where this statutory health insurance and the private health insurance companies are paying all the services provided. And then you have the secondary healthcare market, where out-of-the-pocket payment and the self-payers are allocated. This is the market for everything that is not covered in the primary healthcare market. And to be honest, that's the more complex or the more difficult market to address, because Germany, due to this insurance-based healthcare system, the German people are not so willing to invest much of their own money into their healthcare. They see it more or less as granted that everything is paid by the healthcare insurances. Getting a little deeper look in the health insurances, we have two different systems. One is a statutory health insurance system, where around 90% of the population are insured. Around 100 insurance companies are settled in Germany, and they are called sickness funds, and they are insuring in total 73 million people. So that's the biggest portion of the market is really insured by the statutory health insurance. They are paying inpatient and outpatient services, and they are more or less paying what is agreed by the Federal Joint Committee, the so-called, together with the representatives of the statutory health insurance companies and physician representatives. They are deciding every year what is covered, for what price, in what quality. And since the statutory health insurances cover the procedures according to the price that was negotiated. So they cannot decide on their own what price they are paying. When it comes to the statutory health insurance model, it's more or less a fee-for-service model. So when you're more or less a company that is providing some service or some product in the German healthcare market, it's with 99% security the case that you are not reimbursed directly by the patient. So the patient is paying a monthly fee to the health insurance. When he needs a medical service, he goes to the doctor, he gets his medical service, and you, in most cases, also don't have to pay for it. It's paid by the insurance. The insurance gives the reimbursement to the doctor and gets a bill for it. And when you're more or less providing services in the health insurance or in the first healthcare market, you get paid either by the insurance when you have a kind of selective contract with them, or you have to be paid by the doctor when you're selling your goods to the doctor for the care. The same, a little bit, but different model is for the private health insurances. This is around 47 private health insurance companies across Germany. There's a people, or the richer people and the people that are working for the state are more or less insured, and it makes around 10% of the population. They are following more or less the regulations for the statutory health insurance, but they are paying a little bit more to the doctors, what makes it a little bit more appealing for the doctors to treat these private health insured people. There, you also don't deal directly with the patients, but the patient has to pay first for its service and gets later reimbursed by the health insurance. That's a little bit the difference according to the statutory health insurance. That just as basics to understand a little bit the payment methods in the German healthcare system, in the really health care part. A little bit the same is for the long-term care part. There it's a different insurance. It's a care insurance that is paying for the stay, for example, of seniors in the care homes. Let's come to the challenges in the German market. I already mentioned it's a kind of complex market, many players in, many insurance companies in, different insurance models, inpatient sector, outpatient sector, different reimbursement schemes. And for manufacturers of medical devices or digital health applications, it's important to know what is the right healthcare sector I want to go. Is it really the primary one where I get reimbursement out of the system, or perhaps my product better fits for the secondary healthcare market? That's a question that every company has to answer for itself. So it's all about some basic questions. Who uses the product? Is it the doctor, or is it the patient? Is it a patient-driven solution or a doctor-centric solution? Where is it used more, in the hospital or in the outpatient sector? And what is it used for? This limits a little bit the possibilities of reimbursement and gives you a guidance in what reimbursement scheme you should go in and concentrate on. The question that runs out of this first three questions is, for your product, is there really a reimbursement pathway? And if there are more, which is really the most fitting one? I come to this later with a kind of comparison between selective contract and the DIGA scheme. So really asking the question, who provides the service and where? Who is really the target group? Is it more the medical care, or perhaps your solution is paid or distributed by pharmacies or the medical supply store? That's the first question you have to answer. When it comes to the case, okay, yes, I'm directly in medical care. Is it then really an inpatient hospital-driven solution, or is it in the ambulatory care in the outpatient sector? When you have a product that can tackle both, then it's a little bit more difficult, because the different reimbursement models in outpatient and inpatient care are not harmonized. So when you are having a product that focuses both, then you have to look into both markets and have to perhaps follow two different reimbursement pathways, what makes it a little bit, of course, long-term and cost-intensive. Let's now come a little bit closer to the topic of pathways of reimbursement. When you have to decide it, either if you're focusing on inpatient or outpatient sector, then there are certain or different reimbursement schemes that you have to focus on depending on what your system really is focused on. It's easy in the inpatient sector, so in the hospital sector. That's a rather streamlined topic. It's just depending on, okay, do you find a reimbursement or is it a medical product as investment? For example, an MRI, that's typically an investment good, of course. So it's paid to the hospitals and they are using it for the treatment. When it comes to other medical devices, it's always the question, okay, is my system used in an already existing treatment? So falls under DRG, diagnosis-related groups, or is it a complete new procedure that is not yet in the German system? Then there is an own reimbursement pathway on. Come to this a little bit later on. In the outpatient sector, there are different ways depending if you're a kind of digital health application, patient-centered, doctor-centered, and so on, and you have to find the right way for yourself. I already mentioned in the inpatient sector, normally, when you're having a medical device, you are not directly reimbursed by the hospital, but the hospital buys your system for bringing the treatment and they get money under the DRG system. So this gives a flat rate for a certain treatment. So if you have broken your leg, you get to the hospital gets, I don't know, 3,000 euros, and there is a housing in, there is a treatment in, there is an operation in, and also the materials that is needed for, I don't know, plates for fixing the bone or what else. And the hospital can decide what type of plates they are using for it, what type of instruments, and so on. So it's always a decision, what is the best one for the best price. So you're selling directly under this DRG. You don't get a reimbursement from the system, but you're paid under this reimbursement system of DRG from the hospital directly. So there are codes for everything, and the hospital exactly knows what they get for what treatment and what different material and medtech devices they can use for the different treatments. This is negotiated every year by a committee, and prices are more or less fixed. When it comes to a complete novel product, it's a so-called new product or treatment, then you can also bring it to the inpatient care. But you have to find a hospital that says, okay, I'm applying with this complete new product and treatment that is not yet falling under the DRG. And once they are successfully applied in the healthcare system, they can use your product or your therapy or what else and test it and implement it and get it also reimbursed until it is either officially prohibited or it is accepted as standard treatment under the DRG. So this is more or less for the highly innovative products that are not yet used in German healthcare. And I already mentioned something is really just a pure investment good like MRI, CTs. That's always to be negotiated with the different hospitals. They are getting a little bit extra money from the lender, and then they are deciding if they want to set up a long-term project and investing in this new treatment and use this, of course, for their routine and falling then again under the DRG. This is really just for investment goods, not for consumables. When it comes to the outpatient sector, it's more or less the case that the statutory health insurance, so the sickness funds, are more or less financing all the outpatient care. What is reimbursed and paid by the system is more or less decided by the Federal Association of Statutory Health Insurance Physicians, and they are also distributing the money to the different care actors. What's important, it's a 24/7 ambulatory care that is guaranteed, and this is paid by the system. But it's not one way to this outpatient sector. It's several ways really to coming to this outpatient sector. So as I already mentioned, in Germany, it's yeah, there are many ways into the market, and especially in the outpatient market. There are two different ways I would distinguish between. That's one is more or less a collective care market, and the other is selective care. Collective care just says you have one contract and everybody, every patient can use the treatments, the system, the digital health application, or what else. If you have a selective care contract, then it's just for a certain group. The group that has negotiated this contract and falls under this contract. So this is really the distinguish between this, and yeah, every manufacturer has to check when he falls under this outpatient reimbursement pathway, if there is a way for a collective contract, what is of course the most appealing because you have one contract and every access to every patient, or you're going the selective contract way. I just want to go forward to two different reimbursement schemes under this outpatient sector. So one from the collective contract side and one from the selective contract side. From the collective contract side, I want to just focus on DiGA, digital health applications. I'm pretty sure everybody knows it. Germany was the first country to introduce such a streamlined market access or reimbursement scheme for digital health applications. And that's a classical collective contract. Once you are accepted as a DiGA, all insurances have to pay once a doctor has prescribed the solution. So they cannot decide, I want to pay it or not, they have to pay it. And DiGA is for lower risk class medical devices, class 1 or 2A according to MDR, and can be classical apps and desktop or web browser solutions in combination with hardware if necessary, and more or less a patient-centered digital health application that has not so much interaction, or at least no interaction with the doctor. It's one collective contract and negotiated with the National Association of Statutory Health Insurance Funds. And once accepted, as I mentioned, it's really that insurances have to pay it. It's a streamlined process. You have to apply. You can select what type of application you are doing. You can ask or apply for a permanent listing in the so-called DiGA directory, or you can go for a preliminary intake in the DiGA directory. The question just is, okay, do I provide evidence directly in the phase of application for permanent listing, or do I apply for a preliminary listing and have a 1-year timeline for provide this evidence later? After this 1 year in the preliminary intake, you have then to provide the evidence. And if the evidence is convincing, then you're permanently taken in the DiGA directory. And once taken over in the DiGA directory, you can negotiate the final price and then more or less can earn money with prescriptions. It's running for 3 years already now. Currently, there are 56 DiGAs listed in the DiGA directory. That's pretty good advancing within the last half year. Around 375,000 DiGAs have been used already. So 85% of all prescribed DiGAs were really used by the patients. What's also okay. What is always interesting for the manufacturers? What price can I get reimbursed from the health insurances? The price range is rather broad, from 119 to 2,000 euros, depending on what is in. If there is a price and if it's a one-time prescription or a permanent recurring prescription. What is also interesting, and I saw a figure this week, when you're negotiating your permanent price, I mean, at the beginning, you can negotiate a price of your own wish from the manufacturer side. And between the own price and the price that was then finally negotiated, it's a 65% reduction in price. So this shows most of the manufacturers really set a rather high price, and in the negotiation in the German healthcare system, they are then reduced to a certain basic amount. This has to be calculated, of course, from the very beginning to be on the safe side here. Regarding the selective contracts, these are really contracts with selected health insurance companies. There's the insurance companies, either the statutory ones or the private ones, can select what type of product, procedure, service they want to contract with. And it can be a product or process innovation. It's of course it has to be a medical product, but it can be hardware, software, medical or physician services also. It must not be like DIGA, for example, a pure digital health application. Here it's more open. The contracting partners are normally the statutory health insurance plus the medtech companies. They are making a contract. And depending on what type of legal basis you are selecting, you need either a healthcare provider or not. It can be more or less selective contracts where the statutory health insurances inform their patients and provide the services to the patients directly. Then you don't need this healthcare provider. This applies for certain products or services. When the doctor is included, then you need, of course, the healthcare providers. And then it's, as I mentioned, not one service for all the people. It's just for those that are in the health insurance that is falling under this selective contract, and that are having the right healthcare providers that is also in the selective contract. So it's really a little bit more or very narrow in the beneficiary group. These are two similar ways in the German market. I don't have the time to go too deep into the system. I'm already a little bit over the time. Each manufacturer has to decide what way to go. When DIGA applies and selective contract, it's really a decision internally about what do I want to invest in, what of the reimbursement pathways, because there are different requirements for the ones that are not applying for the other. For example, from the technical requirements in DIGA, you have to fulfill interoperability and usability requirements that are not mandatory for the selective contract, for example. In the DIGA, you have to make more or provide evidence via a clinical study in RCT, what is not mandatory or not necessary in selective contract. On the other way, for DIGA, you don't have to make a health economic evaluation, but for selective contract, it's more or less not mandatory, but needed to convince insurance companies. Or, for example, the involvement of the medical staff. In DIGA, it's not so good idea to involve medical staff. The main function has to be digital and to lie on the patient side. In selective contract, yes, please involve the medical staff and make it more or less as a kind of doctor-centric way also. What we see is that the way to the DIGA is much more expensive than to the selective contract because of the evidence generation and the clinical studies, the RCT. So many companies are now following the way first, or many companies to go for selective contract first, earning money there, and later perhaps transferring to a DIGA when they have enough evidence generated. So you already almost did it. I'm coming to the end now, and then going into this discussion. Just a quick wrap up about what I mentioned the last 30 minutes. As a German healthcare system is quite complex due to the numerous actors involved, but it's also not so complex as it really looks. It really offers good market chances due to its pure size, but also sometimes streamlined ways to the or reimbursement pathways. Focus really on the first healthcare market. The self-payer market in Germany is not so ideal. What I can say is the first step is always from the companies that are not coming from the German market directly, forget about your business model in your home market. You have to adapt your business model, of course, to the German healthcare sector and define what is a reimbursement market and then redefine your, more or less business model. That's from our experience one necessary step. Of course, the optimum reimbursement pathway is always a company individual decision. 3 questions are helping: who uses the product, where is it used, what is it used for? This is normally the first idea to go to what reimbursement pathway, either the inpatient or the outpatient one. And of course, also, is there a reimbursement, or perhaps it's also an investment good or consumable? And that's then a target group definition topic where you have to follow more or less then also your business model on. When you're then following the reimbursement pathway and you have succeeded, for example, to be successful as DIGA, then it's just you could earn money. It's not that you're earning already money. Then the way is more or less also very long. You are theoretically reimbursable, but of course you have to find somebody that prescribes your solution, and that's then more or less a lot of work in marketing and sales to convince the ones that are more or less the ones that are selling your product directly to the customers, so the physicians. And that's a big learning for many of the companies. It's really one of the most cost-intensive parts of the whole business models then really to come to these prescriptions. And that's perhaps my last words on that. I just want to counter-invite you for one topic that we are discussing in one of our communities of practice, as we call it. So a group of companies and people that want to talk about the same topics, and we have one implemented in the reimbursement phase. And on 19th of March, we are discussing the topic of selective contract in Germany and going a little bit more deeper there with one company that is very successful, giving a little bit input in their do's and don'ts and their successful ways, and one consulting company that has helped many companies in applying for selective contracts, for giving a little bit practical backgrounds. So if you're interested, just join. I would suggest that I inform Anne and Jean-Philippe about this community of practice, and that you can, or perhaps we are sharing more or less the information in this group, and then just come along if you're interested, and would be happy to discuss on this selective contract topic with you further. It's in German, to be honest.
It is in German. Yeah, thank you very much, Marco. We already knew before organizing this event it will be challenging to present a country-wide organization for getting like the market access in Germany, especially because Germany is 16 different lenders, and and we will see. But I have this question of Are there like some differences between lenders? Because of course you have mostly presented what happened at the national federal level. So that will be my first question. But before this, we have had one question from Roger about the slide sharing. Yes, we will share the slides after the webinars with all the participants with a link, also a link to the replay. So you will get this information. No problem. Second, I would like to thank you very much, Marco. It was really challenging, and you did it. That's wonderful. But now is the most important part of the event, since we will take the questions from the audience. So, if any of you have a question, please raise your hand. Yeah, Roger, go ahead.
Yeah. Sorry. So thanks a lot for the introduction. It's very helpful. And the question that I have is concerning the DRG. You know, let's say we are selling a software as a medical device to help planning a spine surgery. So the DRG should be specific to our solution, or it should be under a generic name, which is planning of surgery. And if it's planning of surgery, how we can find if it exists or not, and how much it's paid.
There is a catalog of DRGs, and there you can watch what DRGs are more or less existing in Germany. And it can be that there is existing a DRG for the surgery planning, or it's included somehow under the surgery DRG. And when it's under the surgery DRG, then it's more or less in this whole package of the surgery. So, and there is a planning component, what the hospital is more or less somehow calculating in, and they would then just buy your solution in best case and use it for the surgery planning and get it reimbursed via this DRG. If there is, of course, a DRG for the surgery planning itself, then they are more or less getting money for the surgery planning, and then they are free in using your system or buying your system or another that they already have, and according to the best price for value decision in the company. So it's normally under this DRG, you're not applying for something, but you're selling to the hospitals, and they are deciding about using your system under this DRG. So that's not a direct reimbursement, but it's really just for the hospitals. They are earning the money via the DRG, and you're directly negotiating with the hospital about using your system, buying your system, purchasing your system. That's a little bit this topic here. So it's not really a direct contract with the manufacturers and the health insurances.
Okay, so our case, we will be selling directly to the hospital, and will be competing if they want to put it into their procedure, and we'll be competing with other solutions on the same. If they don't use it, they will earn more money. If they use it, they will reduce their margin, basically, right? Because it's coming from the same constant number. Let's say they pay 5,000 per surgery. Will fit in. They will remove some of their margin if they don't. So it's a hospital by hospital case. It's not an insurance case.
It's a hospital by hospital case.
Okay.
Thank you,
and is the DRG catalog available online?
It's available online, yeah.
In German?
In German, I think, yes. I don't know if there is a translation, to be honest.
Google can be helpful there. Any other question? Okay, if no question, I got my question still on the lenders. So are there some differences or not to consider when you are like preparing your business model and your planning?
There are not no differences, I would say. So it's really German-wide this reimbursement topics. So there's not really lender included. The only topic where lenders are included is when you're selling a solution for the public health agencies. then it's every land has its own public health agency. If they want to use a new software, then you have to, of course, more or less sell it to 16 of these public health agencies. And when you're directly selling bigger medtech devices to hospitals, so one land is investing a little bit more than others in the hospitals and their infrastructure. That's the only two ways where the lender really are coming on the table. The rest is really a more or less German-wide topic.
Okay, very clear. I don't see any questions. So again, if no question, I got one. So the big challenge that I see personally will be to convince doctors to prescribe your solutions, especially in the outpatient world. And are there like some tricks that you can use, some association, some network that you can be in, you know? Or do you really need to have your sales forces in place in the different region and to go from a doctor to another one in order to advertise what you do and this kind of thing?
That's a very, very good question. I think there are different ways to tackle with this topic, and we see it especially in this DIGA way. I think the selective contract is rather clear because it's more or less a health insurance that informs mostly their patients or their people that are insured about this service or this treatment, or it's the doctors that are included under the selective contract, because it's a one-to-one contract and they have made this contract because they want to earn money with it or want to have better treatment. If you have such a collective contract, then it's really difficult because it's not a direct contract between an insurance and a doctor, but it's really one contract where a doctor can jump in. And we see it in this DIGA topic that the manufacturers follow different strategies. One strategy is more or less making education to the doctors. So not advertisement, but education about these new methods and new procedures, just to raise awareness and helping them more or less to bring this DIGA topic on the table and to be more open to prescriptions. Others are hiring sales forces, going to every practice in this indication and try to convince. Others are not having their own sales force, but they are partnering with big players like pharma, for example, and they are selling also their product. The question is it high prioritized according to the pills they are selling or not so high? So there are really different strategies how to go there. What is a little bit challenging is there are some legal restrictions that hinder, of course, the advertisement of medical devices and medical goods to a certain extent. So you have to follow some rules, and you're not so much open really to go on the patient side to make a little bit pull effect. You can do it under certain restrictions. That's the fourth way how you are going. Most of them I know are really heading towards the doctors or the insurance companies to provide them more or less all the knowledge to go directly to the prescription phase.
That's clear. Thank you very much. Talking about like the reimbursement and the how much the social security will pay for. So I'm sorry, but I'm French, and I know that the gold standard is a very important thing in France. So if you're able to show how much you bring of going down the price of using this type of technology, because if you really can benchmark a technology against gold standard, it can really change the level of reimbursement that you will get at the end. Is that also the case in Germany? Are there like secret discussion between like industry and the state to define this, to discuss this? And is that taking a long time at the end?
I don't know if there's really background discussions taking place between the industry and the state. I think yes, because the ones that have the gold standard, of course, want to keep it. I don't know. But it's always, of course, a decision that you're benchmarking a new solution according to the gold standard. And I discussed a little bit on this inpatient new treatment methods reimbursement scheme. That's, for example, something that goes clearly according to the gold standard because it's a complete new thing. The gold standard is reimbursed, and here's a new treatment. And then it's reimbursed also, and of course, always with the hope that this will become the new gold standard. I've heard, and we made a community of practice meeting a few months ago on this topic, takes up to 5 years until a new treatment method really is then in the standard care under the DRG. So it's not an easy procedure. It's a long-lasting procedure. You have to bring much data, of course, yeah, but that's always the end goal, of course.
Yeah. Excellent. Thank you very much. Again, do we have a question from the floor? Are you like masterizing everything related to the German market now?
Perhaps I have one practical thing to add. I didn't mention it. Normally, when you're tackling in the German market, it's not the best idea to directly apply to reimbursement, but really make some pilots and some tests with a few key opinion leaders in, either the inpatient or the outpatient sector. That's always key. That's the same, more or less way like in the other countries. So it's not a secret sauce, but you have to do it. And especially when it comes to selective contract, and we're discussing with several health insurances, they are always asking for companies that are not from German. Have you already implemented your system at least in one hospital, in one practice, and have tested it? So that's one thing you have to do. And the second thing is then really always, okay, do you have also a little bit data from testing your solution in Germany? Must not be a full clinical study, but showing really data-driven that your system works, not just in Luxembourg or France, but also in Germany. And that's always there are two questions. The third one is don't go forward to the health insurances too early, because they want to have really a medical product that is already implemented somehow via some pilot studies in the German market. And that's a practical hint from myself, really not to go too early and too direct, go via the healthcare providers, test it, implement it first in a few pilot phases, and then you're coming closer to the German market.
Yeah, thank you. You drive me to my last questions, meaning that you didn't present a lot what you do at Medical Valley, but of course, Medical Valley, you got plenty of like links with hospitals, public research, etc. Can you play a role for supporting like all companies from Luxembourg to experiment in Germany?
Of course, we can play a role. I mean, we do it very often. You mentioned already this 200 startups that we have supported over the last 5 years. These are our startups in our region, but also startups that are coming from outside. And what we are more or less is a network on the one hand, and a kind of service provider on the other hand. So what is our daily business is really connecting companies with potential pilot sites for setting up a pilot, finding the right key opinion leaders. So that's what we are doing, not daily, but I would say almost weekly. We are not always finding somebody that is willing, depends a little bit, of course, on the partners we try to connect, but we have a good track record and many really great pilots implemented from companies outside of Germany want to come to the German market.
Okay, I'm reading in the chat. We have a question regarding the additional cost that you have to anticipate in the DIGA if you compare with the selective contract way. In case of DIGA, do you think that, in the negotiation that you have with the state, you can have like better reimbursement going for the DIGA in order to compensate these efforts that you have to and this investment that you have to do before getting the reimbursement? What is it that you think?
Perhaps first, going towards additional costs, that's really difficult to say. I would say it's 500,000 to 1 million more.
Okay.
Because of the study, depending on what type of product, what type of study design you have, but RCT is normally between 200 and 700,000 euros. Can be also more, depending really. This is the major cost driver. You don't need it in selective contract. And of course, making or fulfilling all these technical requirements on telematics. I mean, it comes closer and closer, the selective contract and the DIGA. So in terms of technical topics, I think in 2 years, it's more or less the same standard. And then it's just a question about the evidence. Is a selective contract really having or the will to have no evidence or very low evidence compared to DIGA? Yeah. This will be the major question, or do they really have to bring later on also these studies on the table? We will see.
Okay.
And the other question was, I forgotten the exact phrasing. Jean-Philippe, can you help me? Second question.
Yeah. So I think the question is DIGA is really worth the efforts? That's the question. Because you invest more, you still have to have the prescription at the end. So in case that you have the choice, what is the trigger? I don't know.
I mean, that's the question. And every manufacturer, of course, has to define it on its own, not knowing how many prescriptions are really more or less taking place. When you're asking the most prescribed DIGA, I think yes, it was, of course, worth the effort because we have 50,000 prescriptions, 400 euro. We have earned lots of money and steady going on because it's not restricted in time. I have one contract, can access to all the, 1.5 million adipositas patients or what else. Everybody can get it prescribed. That's perhaps nice from them to hear. But we have many DIGAs also that said, okay, I have just 800 prescriptions in 1 year. It was not really worse. So it really depends on the success and who you ask.
Okay, unfortunately, we are running a bit after time. Again, thank you very much for your time, Marco. It was, I think, very clear, and thank you for this challenge of presenting everything today, such a complex subject. I would like also to thank the participants of today. I hope that you have learned a lot. And maybe just sharing a few information with you, and sorry because we are a bit late, but I would like to advertise on next webinar that will be on March 26th. That will be on HPC and how much you can use Luxembourg-based services for how much you can use HPC to find some new opportunities and these kind of things. There is also this trade visit to the EMEA where maybe you will have a chance to meet again with Marco. that will be in Berlin, April 9 and 10, and we will provide you with the links. They are in the chat already. Please, if you are interested, you can register there. There is also an official mission to Belgium that will be in April 16, 18. This is a business forum where FTech, with an FTech seminar that will take somehow about 1/3 of the economic mission. So very important. If you can attend, you can register. And of course, I would like to advertise this digital FTech conference that we will have in Luxembourg the 14th and the 15th of May. And here again, this is open to registration. Thank you very much again for your time. Of course, do not hesitate to pop up some emails to us in case you want to get some questions, and we will share as soon as possible the slides from Marco and the records, the link to get the record of the event of today. Thank you again. Have a nice day, and thank you again, Marco. See you soon.
Welcome. You. Bye-bye.
Bye-bye.
Thank you very much. Bye-bye.